It's midnight. Your partner wakes up gasping, each breath a tiny, frantic sound. You rush to the ER. A nurse asks a quick question and walks away, and hours later, you go home with more questions than answers. I hear that story all the time.
Quick safety note up front. If someone has severe chest pain, sudden weakness or trouble speaking, sudden severe headache, or is losing consciousness, call 911 or get immediate ambulance transport. This episode is education, not a substitute for emergency services.
What I want you to leave with today are 3 things: simple lines to say in the moment, a short checklist to carry, and 3 red flags you can't ignore. Those moves change outcomes more than arguing with clinicians ever will.
First, a reality check. Emergency departments treat the sickest first, right? That means arriving early doesn't guarantee being seen first. Severity drives attention, not the clock on your watch.
Who you meet: a triage nurse who takes a focused history and vitals, techs who draw blood and start IVs, the treating clinician who decides tests and treatment, and sometimes a specialist who's consulted. Think of it like a relay. Each handoff matters.
A quick example of what a triage exchange sounds like. The nurse may ask, "How long has this been happening?" That short question is designed to sort urgency fast. Your answer shapes the next steps.
If the triage assessment misses something urgent, you can interrupt with a 1-line escalation. "This started 5 minutes ago. I'm sweaty and dizzy. Please note this as new and severe." Short, specific phrases cut through the noise.
Now, tests. Labs and imaging are tools with timelines. As a rule of thumb, a stat lab panel often returns in roughly 30 to 60 minutes. A CT scan read can be 30 to 90 minutes depending on radiology load, and X-rays are typically faster, but all of this varies by hospital. If you're waiting, ask a specific question. What's the expected timeline for the CT result, and who can I check in with? That turns vague waits into actionable expectations. What do tests actually tell us? Blood work can show infection, anemia, or markers that suggest heart injury. Chest X-rays look for pneumonia or a collapsed lung. CT imaging looks for strokes, big bleeds, or appendicitis. Tests answer focused questions. They don't replace a full exam or your history. Communication beats clinical jargon. Use this 3-part script. Lead with the problem, give a short timeline, and say why you're worried. Example: "I'm her daughter. New severe abdominal pain started 6 hours ago, and she can't stand up. I'm worried this is serious. Can someone evaluate her now?" If you feel dismissed, use a facts-first correction. "I hear you, and I need to add one more fact. She's been vomiting all day and hasn't taken her insulin." That gives clinicians actionable data without escalation. Sometimes you'll disagree with the plan. Here's a short, non-confrontational escalation path. Request the treating clinician, ask that your question be documented in the chart, and, if available, ask for the patient advocate or case manager to review your safety concerns. "I understand the plan, but I remain worried about safety. Could you please note in the chart that I'm requesting observation and involve the patient advocate?" Those words change workflows because they create a documented request. A short real-world example. A woman I cared for was sent home with a vague diagnosis after dizziness. She came back overnight with sepsis. Her family later showed documentation of repeated safety concerns. If a clear request for observation had been logged, she would likely have been kept. Documentation matters. I know that example is heavy, but it's why I press the documentation point. A few written words in the chart change follow-up, transfers, and who gets looped in. Pain control. Be specific. Say a number and the impact. "My pain is 9 out of 10. I can't sleep or eat and I can't move." Then ask, what is the fastest, safe option to control this pain, and how long will it take to work? That invites focused action. If you're sent home, don't leave with 3 things:
a working diagnosis, clear return precautions that say exactly what symptoms require immediate return, and a follow-up plan with a name and time frame. If any of those are vague, ask for them in writing.
Carry a single-sheet med card in your wallet or phone. Name, allergies, current meds with doses, major conditions, and one emergency contact. Hand it to triage with, "Please add this to my chart." That tiny step prevents medication errors.
Okay, 3 quick, usable takeaways. Takeaway 1. Lead with one clear sentence. The problem, timeline, and why you're worried.
Takeaway 2. Ask for specific timelines and written instructions when tests or discharge plans are discussed.
Takeaway 3. Document. Hand over your med/allergy card, note clinician names and times, and request chart documentation if you ask for observation or escalation. That's the paperwork that protects care later.
If you want the printable checklist and sample scripts I mentioned, they're available at faq.nursejessicaconsulting.com/resources. Tuck the checklist in your phone so it's ready when you need it.
Thank you for trusting me with this small crash course in ER advocacy. If this episode made you feel more prepared, please subscribe so you don't miss future practical episodes that separate fact from internet myth.
If you need consultation or resources for your team or law practice, visit faq.nursejessicaconsulting.com. Until next time, stay informed, stay compassionate, and always put safety first.